Welcome everyone. Thank you for joining us today for the webinar. With us, we have Dr. Nitish Dogra. He is a public health physician. Dr. Nitish Dogra is a public health physician with experience over 20 years. He has been associate with the Johns Hopkins University in various capacities, including he done his master's in public health as a Fulbright scholar and a recipient of Community Hero Award. During the pandemic, Dr. Dogra served as an honorary medical advisor to the European Union in India. He also worked with the National Disaster Management Agency, NDMA, during the COVID-19 response. He has trained closely to 100 medical officers and various under National Institute of Health and Family Welfare. He has also taken creative writing as maiden with his maiden novel, The Corona Cinderella, in a modern day fairy tale about a power of human connection set against the time of pandemic. Yeah, we have Dr. Dogra here.
Thank you very much, Siddharth. So a very warm welcome to everybody on 1st of July, which is, as you know, celebrated as National Doctors' Day in India. Some of you may not know, but I guess most do, that it's celebrated as the birth anniversary, also the death anniversary of Dr. Bidhan Chandra Roy, who was the first Chief Minister of independent India, a brilliant physician, somebody who built so many of the renowned medical and public health institutions post-independence, and was also an environmentalist and a very, very valued member of the medical profession, and we all look up to him. In fact, one of the top awards of the medical profession, the BC Roy Award, is named after him, and it's extremely prestigious, and one can understand from the recipients of that award. So that's about Doctor's Day. So first of all, I have the honor of inviting Brian Wahl. Dr. Brian Wahl is assistant professor in the Department of Epidemiology of Microbial Diseases at the Yale School of Public Health. Dr. Wahl has worked for almost 20 years for the prevention and control of infectious diseases, focusing on acute lower respiratory infection in low and middle income countries. His primary research includes a broad range of pathogens, including strep pneumonia, Haemophilus influenzae, Bordetella pertussis, as examples. He is particularly interested in exploring how new interventions and policies affect the epidemiology of respiratory infections in children. Dr. Wahl leads field studies and uses mathematical modeling to address critical questions about infectious disease control performance, optimization, and equity. He's also passionate about strengthening public health research and epidemiology competencies among health professionals in various settings, including India and Nepal. Before joining the Yale University, Dr. Wahl was a faculty member at the Johns Hopkins Bloomberg School of Public Health, and to which I can add that he's also an alum from the school. Thank you. Over to you, Brian.
Thank you, Dr. Nitish, a two-time alum, actually. So, and maintain an adjunct position in the Department of International Health at Hopkins. So I'll just share my screen. I hope everybody's able to see. So is my screen visible?
Yeah, it's visible.
Okay, great. So thank you for inviting me to this webinar. And a happy Doctors' Day to all of the doctors out there. I feel a little bit like an imposter, given that I'm neither Indian nor a doctor, and so to be presenting first on National Doctors' Day feels a little inappropriate from my perspective, but happy to be here nonetheless. So I'm going to talk just briefly about the epidemiology of new COVID variants and what we might see moving forward into the future. And so we've been hearing a lot about new COVID cases in the media. COVID cases are spiking. There are new variants that are emerging that have scary names, scary nicknames, razor blade throat variant. And this is all in the context of SARS-CoV-2, the virus that causes COVID-19, still mutating in the background. The two Omicron descendants that we've been hearing about in the media are recent dominant global genomic variants. The World Health Organization has placed NB181, which we're calling Nimbus, on its variant under monitoring list for its recent increase in global prevalence. And a second variant named XFG, or what we're calling Stratus, has also emerged in Canada and is expanding fast in both Europe and in India. And just to give some context here, laboratory studies have showed that Nimbus binds to the ACE2 receptor more tightly than most previous circulating strains, which helps it to spread more efficiently. Whereas Stratus carries some spike mutations that blunt neutralizing antibodies by roughly twofold compared to the previous dominant strains of COVID. But despite these advantages, I want to stress here that most health agencies have reported no increase in severity associated with these variants, even if some of the symptoms tend to be a little bit different from other previous variants. The razor blade throat, the sore throat that is caused by Nimbus, I think has been gaining the most attention in the media. But overall, vaccines and antivirals still cut the risk of severe disease substantially. The issue with these variants is really speed. Immunity acquired from boosters or from prior infection wanes within months. So as each incremental variant finds enough susceptible hosts, it can keep transmission can keep spreading. And so how does that happen? And what really drives epidemic waves? So I want to just briefly remind ourselves of a key statistic that we heard about a lot during the height of the pandemic, but we haven't talked about maybe so much since then, which is the R statistic, which is also known as the reproduction number. In its simplest terms, it's the average number of new infections arising from one infected individual. And this can fluctuate over time. This is slightly different from R naught, which is the reproduction number in a completely susceptible population. This is the reproduction number, or R, is a number that changes over time, especially as susceptibles themselves change. And when the number is greater than one, of course, we see epidemic growth. When it is less than one, we tend to see an epidemic in decline. And there are really four factors that drive whether or not that R value is greater or less than 1. And they are the duration that a person is infectious. So the longer that a person is infectious, the higher probability that R will be greater than 1. The opportunities for infected individuals to spread infection while they are infectious, the probability of a transmission event given that an opportunity occurs, and the average susceptibility of the population. And so this comes together in a nice mnemonic that we call DOTS: duration, opportunity, transmission probability, and susceptibility. And so with the emergence of new variants that have higher transmission probabilities and with susceptibility changing over time given the waning immunity, we see a lot of infectious diseases, including COVID, fall into a periodicity. And we're starting to see that now with COVID as well. And just to introduce two additional topics, endemic and epidemic. I would argue that COVID is now and has been for some time endemic with periodic epidemic waves, and these endemic undulations tend to be driven by changes in those 4 factors that drive the reproduction number. There was a recent study that was just published that shows that this seasonal forcing and waning immunity are what are really driving the subannual periodicity of COVID-19 epidemics in a number of settings, including in the US. And I would add to that that new variants are also changing some of those factors, including the ability to evade the immune system and drive higher probabilities of transmission, again, driving those opportunities for epidemic cycles. As immunity increases, you then see our come down and an epidemic wave come down. And these various factors are now coming together in ways in which we are now seeing regular seasonality associated with COVID-19. With these new variants, though, I just want to stress that these are nothing of serious concern in terms of severity. The immunity that most individuals have, both through vaccination, through exposure, oftentimes through both, seem to be enough to keep the severity at bay. The recommendations, though, in many countries are still, though, to get your annual COVID-19 boosters to ensure that you do have some levels of vaccine-induced immunity. Obviously, we prefer vaccine-induced immunity over infection-induced immunity. And so just as a reminder, it's really these 4 key factors that change over time, but tend to come together and undulate over time, where we begin to see the periodicity of COVID starting to form, and we can still expect to see annual increases and decreases in COVID. We need to be vigilant of emerging variants, but so far it doesn't seem to be that any emerging variants are any serious concern for severity of disease. So maybe I'll stop there, Nitish, and pass it off to one of our next panelists.
Yeah, one request, Brian, if you could explain that first slide just once again, because that comes as a bit of a new information. And can you, that slide that you showed right in the beginning, can you just summarize that for the
Yeah,
lay audience?
this is just the dominant variance as a proportion on the y-axis of all variants or all samples that are tested in the US on the left, in India on the right. And I haven't included a key here for each of these colors that indicate which variant these are that are primarily dominant in these two countries. This is really meant to just show that the virus continues to evolve and evolve relatively rapidly, and we see these new not new variants, but new subclades within variants emerging, dominating, and then being replaced by other variants relatively quickly in most settings. I will say that the numbers that inform the graph on the right from India are from relatively small sample sizes. So you see the dominant purple period between the kind of last quarter of 2024 and into the first quarter of 2025 is really driven by a very, very small number of samples in the order of, I would say, less than 10. So these have just been normalized to 100% to visualize. And so this does not give a sense of the magnitude of cases in these countries, but rather the dominant variants or sub-variants within each of these countries.
Okay, thank you. Thank you very much. So, second on my speaker list is Dr. Ashish Goel, and he's a professor and head of the Department of Medicine at Dr. Bhimrao Ramji Ambedkar Institute of Medical Sciences, Mohali. It's known as AIMS Mohali, AIMS. And Dr. Goel holds a master's in public health with a specialization in epidemiology and biostatistics from Johns Hopkins. And he completed this program under a Fulbright fellowship. He's led significant research, including an ICMR project on the psychosocial impact of COVID-19 on older persons. His publication on the subject addressed various COVID-19 aspects such as PP effectiveness, hyperglycemia, and the virus's impact on healthcare delivery and the elderly. Dr. Goel is also the president of the Indian Academy of Geriatrics. And like me, he's I should not say like me, but he also is an acclaimed author of books like Doctors Do Try. So over to you, Ashish.
Thank you, Nitish, for that kind introduction. And let me make a small correction and disclaimer. I'm no longer the president of the Indian Academy of Geriatrics, although I could be the immediate past president for that matter. So let me begin by saying good morning or good evening, depending upon which part of the world you are attending this seminar from. So my brief today is to talk about the resurgence of COVID. I will be talking in about 5 portions of the situation currently, which Brian has already explained, the clinical preparedness that we have, the lessons that we have learned from the previous pandemic, the future directions, and I will summarize in the key messages that I would like people to carry away from this. So like what Brian was talking about, yes, we have new mutations, and coronavirus or the COVID virus is known to be highly mutagenic, with producing practically mutations every few weeks. The strains LP81, NP181, and XFG that Brian was talking about are there and have become common conversational terms these days. The older symptoms were fever, cough, and breathlessness at presentation, but this newer symptom which has been observed with the newer strains is the razor blade throat, where people complain of a razor blade feeling in the throat, which is self-limiting and then goes away in most cases. Moving on to how clinically prepared are we as compared to the previous pandemic. Yes, at that time we were caught unaware largely, but now we have arms and we have an armor. So when I say arms, I say we have some drugs in our armamentarium which we can use, and we have an armor in the form of vaccines which people can wear. Also to mention here, the INSA-CoG, or the India SARS-CoV-2 Genomic Consortium, which already has 10 laboratories across the country looking and monitoring the genomic structure of the virus as we go ahead. So this slide will give one basic message to the doctors who are probably attending this. And I would like every one of them to carry this basic principle of therapy. Although I'm not going into great details of the specifics, but here is a basic principle of therapy which says that every phase, in the early phase of the disease, which is within the first week of the disease, when the virus replication is high, the patient may have very few symptoms and is just presenting. At this point of time, it's most meaningful to start antiviral therapy with whatever drugs we have, maybe remdesivir or ritonavir or whatever armamentarium of antiviral therapy we have. Also, this is the time when we can give passive immunity regimens, maybe convalescent plasma regimes or other things which will boost up the passive immunity of the person. Once we go into the later phases of the disease, which usually manifests as probably the critical disease or severe disease, it is believed to be an excessive or an aberrant response of the inflammatory system of the body. So this is the point, and this is the time where it is logical, and theoretically this is the point where anti-inflammatory therapy, which may be steroids or IL-6 inhibitors or JAK inhibitors, which will come into play, and they will function the best. So this is one key message about therapy, which I would like people attending this webinar at least to carry home with them. Coming to the public health lessons that we learned from the previous pandemic, yes, forewarned is forearmed, as we all know. Probably this time, if we come across a strain which is as as severe and as transmissible, we will probably not be caught napping. We realized in the previous pandemic phase that vaccines can be and were developed at speeds which were probably thought, faster than it was ever thought that was possible. We learned the power of social media platforms and how these could be mobilized and channelized into an effective machinery or an effective tool to fight against the virus. We also found that the online webinars like this one are a gift of COVID, where while sitting at the comfort of my home and with all symptoms of a COVID infection, cough, fever, breathlessness, myalgia, fatigue, I can still deliver a webinar talk on the preparedness for COVID. Well, let's talk a little bit about the future with a disclaimer that I'm neither a seer nor a fortune teller. But yes, it is not about if, but when will the next pandemic arrive? Probably we will be better prepared to predict it if we are monitoring it more closely. Obviously, mutations will continue. New strains will continue to evolve and emerge, sometimes more rapidly than ever before. But we can identify them quicker and faster than before, and we will be better prepared. So if I say one takeaway for any administrator or any clinician or any doctor in this who is in a situation of making policy for their institution working in India, one message to carry away and take away from this would be that every healthcare facility, whatever its size, should constitute a rapid response team to understand and to effectively plan for surge capacity to at least 2 times of what their daily routine is in the emergency, in the outpatient, and in the admissions. So any hospital or a healthcare delivery facility should create a rapid response team, which should be deciding who acts, when they act, what they do, and how they act, including providing training to their healthcare workers and networking with other healthcare institutions in the region. And if this is in place in advance, it could take away and save a lot of effort which goes into firefighting at a later stage. So coming to my last slide and a few key messages that I would like to leave people with some food for thought. So it's not a battle that has to be won. So these are words from a famous writer from the book When Germs Travel, Howard Markel, a professor of history, says it's not a battle that has to be won. It is a beautifully synchronized war of survival that continues in nature between the human beings and the microbes. Sometimes the balance shifts this side, sometimes the balance shifts that side, but it is not a war that anyone will win, but it will continue for a long time to come. The question is not if the next pandemic comes, but when the next pandemic comes. Yes, the truth is unsettling, and it is important to remember that misinformation is an integral part of any emergency, any pandemic. There will be a lot of misinformation, and it selectively captures those who are more vulnerable to disease. And it's important while managing any pandemic or an emergency situation that we handle and have ways to give the correct information to the people so that they don't fall prey to misinformation. 3, borders are blind and viruses don't need passports. So global threats also need a uniform, coordinated, unified global response. And every city, however far or however near it may be to your physical location and geographical situation, yet is a sister city because germs travel in living beings who travel to distant places and quicker and faster now than ever before. Science is slow, but yes, research is our only compass. And my final words that history will repeat itself, and that is probably the only lesson that we can learn from history, that it will repeat itself. And with that, I rest my case for my initial presentation. Over to you, Nitish.
Thank you, Ashish. So that was a very interesting talk, particularly what you mentioned about the surge capacity. I think that's something that gets, it's something that's complacent. Complacency does set in at times. I've seen that on the field, and particularly where you mentioned that it should be, at least to the extent that you have frequent mock drills and tabletop exercises, to the preparation that is vital, that at least into 2, that level of preparedness that must be there all the time. So thank you very much. So with that, we go on to our next speaker, who's also a distinguished alumnus from Hopkins, Mona Sharma Rana, and she's a mental health specialist. She's a mental health advocate and cognitive behavior therapist with over 20 years of experience in the field. She holds a master's degree in public mental health from Johns Hopkins and in psychotherapy from the Beck Institute, United States. And Mona has worked across diverse domains of mental health, including clinical service delivery, public health research, capacity building, and advocacy. And her work is grounded in evidence-based practice and driven by a deep commitment to accessible, affordable, and compassionate mental health care for all. She currently leads the Manurathi Foundation, a community-based organization focusing on promoting the mental health well-being, building awareness, and providing grassroots mental health support. So with that introduction, over to you, Mona.
Thank you so much, Nitish, for the introduction. So whatever I present, all my presentation today would be based on the experience and some of the people of my team and people I worked with during pandemic. I know they are present here, and all my learnings, most of my learnings that I'm going to present today, I owe it to my team and people who helped me to understand, uh, mental how to implement mental health interventions during an emergency situation like COVID-19. So first of all, why do we need to talk about mental health after any disaster? Because mental health and physical health, they are interconnected, they're closely connected. When I talk about mental health, I'm not only talking about absence of mental health conditions, I'm talking about well-being, about mental health well-being also. Okay, so first of all, any disaster or an emergency situation like COVID-19 would have, we have seen, it would have a psychological impact. Psychological impact which gets overlooked. And because psychological impact gets overlooked, it further increases the burden of the disease. So during pandemic, we saw in the first year, we saw a sharp increase in mental health conditions, especially depression, anxiety, panic attacks. There was, the WHO study shows that there was about 25% increase in prevalence of depression and anxiety in the first year of pandemic. Of course, there was also increase in grief, panic, and chronic stress. Some of these conditions continue, there's a ripple effect. Some of the impact we continue to see since 2020, like, especially the burnout in health professionals, the vulnerable populations, the at-risk populations. Even after 5 years of pandemic, we continue to see the impact. I also know some people who had a relapse, who had pre-existing mental health conditions and who relapsed during pandemic because of lack of access to care. And a few of them have still not recovered. They're still struggling with with their mental health, the deteriorated mental health conditions. Also, during the pandemic, and I'm sure all of you have heard about how loneliness is the next pandemic that has hit. And at-risk populations like elderly, young people, women, social disconnection and loneliness they continue to experience. So of course, Nitish asked me to talk about resurgence of pandemic and the impact, but I would like to state that the impact of the first and the second wave we continue to experience in many forms. It also widened the treatment gap. So during the pandemic, people who had pre-existing mental health conditions or who experienced mental health conditions, they could not access for 2 years. The access to mental health services, it was almost blocked. Most people, anyways, in India, we have about 9,000 psychiatrists total, which is like 0.75 psychiatrists per 100,000 population. So during pandemic, that figure reduced even further. For most people, psychiatric services were inaccessible, especially those who were dependent on public health services for their mental health care. And increased vulnerability in at-risk population. At-risk population, I would like to talk about elderly and young people, especially in young people. We continue to see, so when we meet young people or we meet elderly, mostly when we look back, the problems, the issues, the psychological distress usually started around pandemic or soon after pandemic hit. Burnout in frontline workers, again, we started some support groups. I was also part of the study that Sangat is an NGO, mental health NGO in India, did on frontline workers, on healthcare workers. After that study, we have started a support group for frontline workers who provided health services during pandemic, and we continue to run that group. That group has just expanded, it has become bigger, and we realized that burnout, that it has a ripple effect. Most of the frontline workers, they continue to experience the functional distress, burnout, or anxiety, instability, even after so many years, after 3 to 4 years of pandemic. The key learnings after based on the mental health services that we provided during pandemic. First of all, we have to build resilience for future crises at individual level, community level, and health system. At individual level, by training individuals in emotional regulation. Now, there is a technique of psychological first aid training. Psychological first aid training can take care. It's like physical aid training. You don't need to be a psychiatrist or mental health professional to be trained in this. Even using techniques like psychological first aid training to build resilience in individuals, community, by making them more. So, like you can tackle issues of loneliness or social isolation by building resilience in communities, by increasing the social cohesion, which happened, if you remember, that during the second wave of pandemic, communities started, the cohesion started increasing, people started coming out to help each other. But if we can have communities, even we don't wait for the disaster, we have communities which are cohesive, which are supportive, that which builds the resilience. Health system, of course, mental health should not be standalone, service. It should be integrated. So I know that a lot of, even before pandemic, places like Red Cross or MSF, they integrated mental health in their disaster preparedness. So we should, all health systems, whatever health system or disaster management program it is, mental health should be integral part of the training. And I have seen this, this improvement, that most programs, public health programs now have mental health trainings, or they have integrated mental health component in the program. Psychological first aid. Now, psychological first aid training, this is available, this is free. My organization provides this training every month for free to frontline workers, to mental health professional, teachers, students. And you would also, Johns Hopkins School of Public Health also has a platform where you can, this is a 6-week training. You can take this training at no cost. Then strengthening the informal care system. For example, peer support group. Like I was talking about the peer support group that we started for health professionals. Self-care, training people in self-care, health professionals, students in self-care. So basically training the at-risk populations in self-care before is another key learning. Next is normalizing the conversation mental health. We did not, so I remember we saw a sudden upsurge in mental health distress calls and mental health conditions. We don't wait for distress calls. We don't wait for the distress to increase to start talking about mental health care. So mental health care, we know any disaster is going to have an impact on mental health. So start talking about it. Integrate into, when you talk about disease, also talk about the mental health impact. My next slide, this I have taken from IASC. So this is a pyramid which shows about, this is a pyramid of services for during any disaster management program. So at the bottom is, so this is a multi-layered program. At the bottom is advocate. So at the bottom are the social consideration, basic services, security. So basically, these are the services that, these are for the usual well-being. So something like, during COVID, it was like, hygiene kits. So there was anxiety about virus spreading. So, availability of hygiene kits or availability of scientific, proper, right information for people in the language that they understand. This is the advocacy for good humanitarian practices. So some services that should be provided to everyone at the base level. So if you provide these services to everyone, then you take care of the base anxiety or panic. Then after that comes activating the strengthening community and family support. So whatever existing social networks are there, for example, teachers, Anganwadi workers, ASHA workers, engage them, or students, young people, engage them to provide social services, so social network, to improve the social network of the community. After that comes the focus psychosocial support groups. These groups for, like, peer support groups. Peer support groups, say, for women who are experiencing domestic violence, peer support groups for elderly who are experiencing loneliness, or for frontline workers. At the top comes the clinical services. So the idea is that most services can be provided at the bottom layers, at the bottom 2 layers, where community resources are needed. These are not intense services. These are not resource intense services, but they should exist before the disaster happens. My last slide is on integrating mental health in the ongoing care system. So after pandemic, lots of organizations came to us, health organizations, some social security organizations, that was asking, how do we integrate? Do we need a psychiatrist or mental health professional in our organization to integrate mental health in our ongoing care system? Now, this is a model that we have come up with after our work in different disaster or humanitarian contexts. That if you want to integrate mental health in your work, this is a very basic model that you can follow. So mostly when you start working with people or systems during disaster, these are 4 journeys. Mostly people are feeling alienated. They're feeling helpless. There may be abuse or suffering. And what do we do? So every service that you're providing, whatever service it is, about food or health or hygiene, whatever service you're providing, ensure that it enhances the sense of belonging. It makes people feel in control. It improves or it aids dignity, and it adds purpose. If you can take care of these 4 elements, these 4 journeys, then you have integrated mental health in your care system. That's it. Okay. Thank you so much.
Thank you, Mona. So now we can go on to the questions. So the first question I have is for Brian, which is related to the surveillance system in India. And what do you feel about it? Is it adequately funded? Is it well structured enough to pick up the variants or clusters in real time?
Thanks, Nitish. So I think countries everywhere, not just India, have a worry of mine is that countries around the world are not investing enough in core public health infrastructure. This includes public health surveillance networks, laboratory capacity, data systems, supply chain reserves. And these are the things that we need in place, not just during, so to say, peace times, but also as an outbreak is emerging in order to respond as quickly as possible. I worry that in the US, reductions in budgets for these core public health activities may result in unnecessary disease outbreaks and poor responses to those outbreaks. India, thankfully, has not been making cuts to its public health budgets, but as a proportion of its overall GDP, still low relative to comparable countries. And so I would love to see the budget for core public health activities go above 1% of GDP, which is around what it is currently. So the last thing I'll say is there were investments that were made during COVID in terms of response efforts, and that's a great thing. And some of those investments will serve us in future outbreaks as well, and even when we're not dealing with outbreaks. But a lot of that infrastructure requires ongoing investments as well, not just in terms of maintenance for that infrastructure, like laboratories, but also increasing human capacity, human resource capacity for ensuring the delivery of those core public health functions.
Okay, Thank you, Brian. Next question for Dr. Ashish. So question is, how do you communicate with your patients about the risk of COVID-19?
Yeah, thank you. Thank you, Nitish. So that's a very interesting and a very pertinent question. And it's a very difficult situation when patients would come to you in the outpatient or call you on the phone and want to know about what they should do. Because at these times, you need to strike some kind of a balance. You don't want to create panic, but you do want to create enough concern so that they do listen to you. So it's important that I tell them that one, vaccination is important if you have not been vaccinated. It's time that you get vaccinated. If you have been vaccinated, it may be time for a booster. And definitely the importance of protective behavior, whether it is masking or whether it is hand washing or appropriate social etiquette, can never be slackened, whatever phase and whatever stage of infectious disease we may be in. In addition, I do tell them that yes, if you are older, if you have diabetes, if you have any comorbid illness, obesity, or dyslipidemia, then these are conditions which have been shown to have increased severity of disease and maybe is associated with more mortality. Then you need to be more careful and report if symptoms appear or persist. In addition, I always tell them that probably health is an investment, which works best when you purchase it in advance, rather than you pay it out every time a crisis arises or a health situation worsens. So it's kind of an insurance which you need to work with. Yeah, that would be what I would tell them.
Thank you, Ashish. Now I have a question for Mona. So Mona, you spoke very extensively in your presentation, but in particular, as far as the caregivers of those who are suffered from mental health issues, so what has been your experience? What are your key takeaways for the caregivers? I'm not. But one is the caregivers, the other are the care providers, which are the doctors. So whatever you'd like to address.
Thank you, Nitish. That's I think we should address both caregivers and care providers. Both are important to talk about. So first of all, for caregivers, I think one is that strong social connections is one thing that pandemic has taught us. It is like, and of course, mental health professionals have been saying it again and again that mental health is too important to be left only to psychiatrists or mental health professionals. It should be everyone's job. So improve social connections, and like I said, don't wait for the disaster to happen, don't wait for pandemic again, just keep working on social connections. Second, for caregivers, especially families where there was existing or there were new cases of mental health conditions, one was to have routine and structure. No matter what, don't keep the routine as normal, as close as and structure as possible. Third, we always keep emphasizing was physical activity, especially for senior citizens and for young people. Only trust the reliable information. Don't keep looking or searching for information. Don't doom scrolling the whole day. Set a time. A lot of people who suffered from anxiety or panic was because they were continuously looking for information. Set a time. It's okay to worry, but set a time to worry. So instead of worrying the whole day or looking for information the whole day, set a time when you would do that. Say for an hour in the evening or so. Also, some practices like for some people, I know spirituality, yoga, or meditation. Such practices help. So understand what helps you. What has helped you in the past? What helps you to feel more connected, even if you are not connected with outside world. What helps you to feel more connected with yourself? What helps you to deal with anxiety? Understand that and use those strategies, at a time like this. And most important, seek professional help. If there is a need, talk about, of course, before that, if there is anxiety or depression or any condition that you are experiencing. So, most carers, what they do, and that I see not only during pandemic generally, if there's a person with mental health condition or any health condition, their focus goes to that person so much that people start ignoring their own needs. Don't ignore your needs. If you need help, seek professional help. Okay. For care providers, yes, like I said, the burnout is still, when there was cases of resurgence increase, the burnout. I also saw trigger, reactivation of trauma in families who lost their loved ones during COVID, as well as in health professionals. You know, there was a reactivation of trauma that we saw, and that's very common, after emergency situations. So for care providers, I would have the same suggestion that take care of your mental health, seek professional help if you need. Join support groups, and this is something very important. More than professional help, support groups I have seen are more beneficial, more effective when it comes to mental health. Sorry, when it comes to mental health preparedness of the frontline workers. Like, not everyone needs psychiatrists. Remember that pyramid. Not everyone needs psychiatrists. Not everyone needs specialist mental health services. But everybody needs support. Everybody needs to learn some self-care. We all need psychological first aid techniques. We need a strong community support. So let us build that for both care providers and caregivers.
So I think we'll end with the last round. That much time we have. So we'll go in the reverse order. So Mona, the one question I wanted to ask you is that what about the case of the COVID orphans? And also there are a lot of people, there are a lot of widows, a lot of widowers, especially in the second wave, right? So what has been your experience whereas vis-a-vis the mental health of these special categories?
So you mean what has been done after the pandemic for these groups?
Yeah, what has been done and what has been your experience about the trauma and what has been done here?
I think the trauma has been intense, Nitish, and like I said, some of these groups that we continue to work. One group that I would like to mention is women or children who experienced abuse during this pandemic. Who were widowed, who were orphaned, and of course who lost their loved ones, but also who experienced abuse and who continue to experience abuse or trauma. Okay, the uh, the impact continues. So the work that we start with some of these groups is still ongoing. So most of this group we realized they needed, few of them needed specialist care, but they all needed ongoing continuous support. We as an organization, we could not provide to all the groups, but the needs are intense. The gap is huge there. And I don't see now during the pandemic, I did see some, helplines or some organizations or professional coming forward to help these groups, but most of them stopped after the pandemic. For example, organizations like Red Cross, they also started helplines for some of these vulnerable groups, which stopped, obviously because of the resources had to go to other programs also, we stopped. So this group that you talked about continue to experience a widened treatment gap.
Thank you. So I'll just request now for final closing remarks because we are completely out of time. So Brian, I'll start with you. Please go ahead.
No, thank you, Nitish. I mean, the only thing that I would add is that in normal non-pandemic situations, but also in epidemic or pandemic situations, centering equity, I think, is an important component that we missed during the pandemic, especially with regard to the distribution of vaccines globally. So that's something that, as we've all been saying, will occur once again, a pandemic, and having an equitable system for distributing interventions, including vaccines, I think will be really critical. I also think that better communication with the public in order to gain and strengthen trust in public health systems is incredibly important. So thank you for having me today. Nitish, I realized that we didn't get to hear from you too much today, so I hope in your closing remarks you can tell us a little bit of your perspective, both on the personal front as well as on the professional front as well.
Thank you. So yeah, so well, I don't have much to say except that it's been a very enriching experience. COVID, we had a very small team. We used to work with the European Union. We just had a virtual ICU, but we did whatever we could for the EU delegation and the 27 member states. That was my professional hat, but apart from the work with NDMA and the training with NIHFW, my book is just a fun book that I wrote about just being connected. Like Mona said, just the importance of being connected in the times of COVID, and how just sometimes just having just knowing a doctor, could just save your life. So that was how how important the connections were. So that's what it was all about. Ashish has of course written something much more deeper, so that's for him to mention. So over to you, Ashish. There is a question, if you can also just state that, on how we could incorporate AI and digital tools in COVID surveillance.
So yeah, thank you, Nitish. I think I already answered that question in the question and answer box itself. That yes, the tools of artificial intelligence are already being used in surveillance, in reading the big data that is pouring in terms of disease reporting and surveillance. And any deviations in that data are already being recorded and addressed. So in my final comments, I would probably like to tell a small story in a minute. So let me take you back to 1882, and this was the time
before you tell that story, I have to tell here that Ashish did such a commendable job in the COVID-19 pandemic. We had acclaim from all over for our work. He doesn't talk about it, but he got acclaim from none other than the Secretary of State of the United States. So that was something remarkable. But yeah, fantastic work, because you were right there, risking your life day in and day out, so you were on the front lines with your PPE. I remember that. So you're a real hero.
It was just that we were caught in the storm and there was nowhere else to go. So you were caught in the storm and there was nowhere else to go except fight. So there was no option available other than that. So yeah, this little story that I was talking to you about is incident that happened in 1882, and it remains relevant till this date and will be like this forever. It was Bellevue Hospital, and Robert Koch had just demonstrated to his class of laboratory students the presence of tuberculosis bacillus. And Herman Biggs was a student in that class, and he was so excited that he ran with this news to Dr. Alfred Loomis. So Alfred Loomis was called the grand old man of New York medicine, and he was also the president of the American Association of Physicians, and he was the founder president of that organization. And after a few days, Dr. Loomis walked into the hospital amphitheater. He looked around and he said, people say that there are bacteria in the air, but I cannot see them. And the entire class roared with laughter. And this story, when it was narrated to William Welch, who's another famous pathologist or father of pathology from Johns Hopkins, he said, that's too bad, because Loomis is such a nice man. So we will always continue to not see what we cannot see, and we will not acknowledge his presence, and we will continue to ignore what we cannot see until it strikes us with such a great and sinister situation that we are in a disaster, and we are all firefighters. We plan less, but we are good at firefighting. But hopefully, we will be able to fight the fire better when it comes next time.
Thank you. Thank you. And any 30 seconds closing remarks, Mona, that you may have?
I think this is for all the health professionals that we should take care of our mental health as well. We are sometimes so busy taking care of others that we forget to care of for us. So
Okay. So thank you very much, GKII, the Gupta-Klinsky India Institute. Always great to have this India home for all of us, and it's a body which not only unites the alumni but also the faculty, the staff, the students, and so much of the work that gets integrated across Johns Hopkins, which is not just medicine and public health, though that's what it's most famously known for. But there's a fantastic engineering school, a great school for this undergrad school, and a great school for the advanced international studies, amongst others, right? There's a whole lot of schools out there. And so it's such a great feeling to be part of Hopkins. And we are so grateful that we could communicate to all of you who joined us, and some of you might be wanting to join the Johns Hopkins University in some campus or the other. And as alumni, we are always there to help you for your preparation. So we are there for not just for COVID or any other topic, but in case you ever want to be part of Johns Hopkins, we are there for you. So thank you very much. Thank you. It was a wonderful session.
Thank you, everyone.
Over to you, Siddharth. Over to you. Siddharth, over to you.
Yeah. Thank you, Nitish. Thank you, Dr. Ashish and Mona and Brian. Yeah. And thank you, everyone who attended the session. Look forward to the next session soon. Yeah.
Okay, bye-bye.